I want to show you the tumorigenesis of the brain tumor. Then we pass to how the radiation kills
Your doctor may recommend intensity-modulated radiation therapy, a procedure that treats certain forms of cancer to kill cancer cells or control their growth. The cells in the body grow and divide as part of the normal cell cycle. The cell's nucleus controls this process. Inside each nucleus, genetic material called DNA contains the instructions for directing this process. Sometimes the cell's DNA becomes damaged. Normally, the DNA responds by either repairing itself or instructing the cell to die. In cancer, however, the parts of the cell's DNA that direct cell division become damaged. When these sections are damaged, the DNA is unable to repair itself. Instead, the unrepaired DNA causes the cell to grow and divide uncontrollably into more damaged cells called cancer cells. A tumor forms as the cancer cells multiply and displace the normal cells. Radiation kills cancer cells by inflicting overwhelming damage to their DNA. The tumor shrinks as the cells stop dividing and die. If the tumor is in your head, your radiation therapist may make a mesh frame or mask that will keep you positioned correctly during the IMRT. Or you will get small permanent tattoos to help align the IMRT. Next, your therapist will do a CT scan of your head to get a detailed picture of your tumor and its borders. Your doctor will use the scans to specify the three-dimensional shape of your tumor and vital tissues nearby. The tumor's shape, size, type, and location help your doctor determine how the IMRT beam should be adjusted to hit your tumor and avoid healthy tissue. During your procedure, a medical linear accelerator will deliver an X-ray beam to your tumor. A computer inside the accelerator will adjust the beam with a device called a collimator. The collimator will adjust or modulate the intensity, direction, and shape of the radiation beam. This feature allows higher doses of radiation to be delivered to your tumor while sparing your healthy tissue around it. You may receive many radiation treatments over days or weeks. This allows your body to recover between treatments and to kill as many cancer cells as possible. Side effects are usually mild and occur only in the treatment area. Common side effects include localized skin irritation, localized hair loss, or inflammation and swelling near the tumor location.
In the first part of my communication, I showed to you the first video in which you have seen how the radiation kills the tumor cell. And now we will deal with the secondary intracranial tumors following this radiotherapy. We will deal with a systematic review of some case reported. So I present to you some case reported. The first one is the radio-induced temporal meningioma. The second one is the pituitary carcinoma. And the last one is the glioblastoma. Yes. So, as you know, the radiotherapy is a valuable treatment in the management algorithm of the tumor of central nervous system. However, the risk of emergence of the second brain tumor can appear, and it is our major concern. As I said before, I will present to you some case report. I start with the first one, the pituitary carcinoma. The pituitary carcinoma is considered as extremely rare, and distinguishable from the pituitary adenoma, and this is in the histopathological ground. And this pituitary carcinoma have a poor prognosis. And for the modality of or the most common site of metastasis, we have the intracranial metastasis and also the systemic dissemination. And as you know, in one conference of 5th November, I present to you the different form or different kinds of pituitary adenoma. I say that we have two kinds. We have a non-functional pituitary adenoma, and we have functional pituitary adenoma. So between the functional pituitary adenoma, we have a corticotroph pituitary adenoma. And this kind of pituitary adenoma can have an aggressiveness. So for the incidence of distant metastasis, we noticed that this incidence is very high in the case of corticotroph carcinoma when we compare it to the other kinds of pituitary carcinoma. And the mode of dissemination is the systemic dissemination. The major causes or major mediator of malignant transformation of pituitary adenoma into pituitary carcinoma is the tumor aggressiveness. In this case, we have Ki67 more than 10%. The second modality is the therapeutic modality of surgery. And the last one is the radiotherapy. In our conference, we are based on this radiotherapy. So this radiotherapy can induce the emergence of a second brain tumor. So we present to you this case report of one female patient with a Cushing disease who underwent 3 transperineal surgery with a pathological finding of corticotroph pituitary adenoma, including Ki67 expression less than 3% at the first surgery. This patient achieved hypocortisolism after the first surgery, although the ACTH levels remained slightly elevated. This patient returned 5 years later with a fast worsening of hypercorticism, and imagery MRI showed here the invasion of the clavus. So this invasion led to the 4th surgery with radiation. So after the 4th surgery, the patient received radiation, and at this time, the immunohistochemical revealed a strong Ki67. At the first surgery, Ki67 is less than 3%, and here with the 4th surgery, Ki67 here is between 10 to 15%, and we have also a strong expression of P53. This is the characteristic of this pituitary adenoma, but we noticed a few months later the emergence of some metastasis. We have a liver and the lumbar spine metastasis. And unfortunately, the patient died after a few months due to the lung infection. So here we pose two hypotheses. The first one is perhaps the cause of this metastasis is the aggressiveness of pituitary adenoma. And the second one, perhaps, second hypothesis is perhaps the radiation induced the appearance or the emergence of this liver and spine, lumbar spine metastasis. This is the first case. The second case is radio-induced meningioma. This is an article published this year. Here we have one patient who have received radiotherapy at the age of 20 years. And this is for the ependymoma of the posterior cerebral fossa. So after 17 years, she consults for hemiparesis, seizure, headache, which appear 4 months before her admission. The neurological examination revealed, firstly, intracranial hypertension syndrome, secondly, a left hemiparesis, and also the secular kinetic static cerebellar syndromes. But the radiological examination or exploration, this CT scan show no recurrence of a posterior fossa ependymoma. However, here we have the emergence of this process, and exactly in the left temporal. So our patient underwent a surgery, a maximalis surgery, and the diagnosis of meningioma grade 1 is confirmed by the histopathological examination. This is the post-operative cerebral scan and post-operative MRI for our patient here. This is the place of a temporal meningioma. And last case, it is glioblastoma. As I said before, the glioblastoma is considered as a malignant tumor. So this glioblastoma can appear as a consequence of radiotherapy. We have this article published in 2019. Here we have a frontal giant cell glioblastoma radio-induced. This is a rare case report. So here we report the case of one patient, 42 years, who received radiotherapy at the age of 20, and this is for the nasopharyngeal tumor. So at the age of 20, he received this radiotherapy. And later, after 20 years, he consults for a left hemiparesis, and radiological exploration reveals a dermatogenous right frontal process. And our patient underwent a maximalis surgery, and the histopathological study show or confirm the diagnosis of giant cell glioblastoma. We pass now to the discussion. As you know, the first radio-induced tumor was described in 1982, 7 years after the discovery of X-rays. And the definition of radio-induced tumor was based on the Endera criteria initially established by one author named Cohen. Cohen said that the location of this secondary brain tumor is in irradiated territory, and this is after a latency period more than 5 years, with a different histological type from the first brain tumor. And also, we noticed that this patient haven't a genetic predisposition of metastasis. So the criteria established by this author are, firstly, the location in irradiated territory. Secondly, a period of latency period more than 5 years. And the last one is without any genetic predisposition to develop a secondary brain tumor. And as you know, the central nervous system is considered as one of the sensitive tissue, and this therapeutic can be no threshold this kind of tissue. For the case of pituitary tumor, this radiotherapy has been used, and this is for over a century. And despite the advances in the surgery, the medical treatment, it remains a valuable tool in the management algorithm of primary or recurrent pituitary adenoma. And also it is the same case of craniopharyngioma. And this radiation is characterized or is associated with a light toxicity. This is the first one. And it can present late effects. What are the late effects? The first late effect is the risk of second brain tumor. This is why we consider that this radiotherapy as have a role of induction of brain tumor. So, as I say, this radiotherapy have inductive role in the emergence of second brain tumor. And there is some authors who show this result. We have one Japan author named Tanaka, who presented some case report and showing cerebrospinal metastasis after radiation and gamma knife treatment. And he suspects that the repeated radiation therapy for pituitary carcinoma, pituitary adenoma, aggressive pituitary adenoma, and also the intracranial tumor. So the repetition of this radiation may induce a malignant transformation and also the emergence of multiple spinal metastases. So I have another article, the last article published this year. This is a British study. It is a retrospective cohort study involving 6 adult centers on the crime center in United Kingdom. And here we have more than 3,000 patients divided into groups. The first group is the patient who received irradiation, and the second one is the patient who didn't receive irradiation, and we consider this group as a control. So this data suggests that the radiotherapy is associated with this person, 82% increase in the risk of the second brain tumor, and this is only in the case of irradiated patient compared with the group of the control. So this group confirmed the result that this radiation can induce the brain tumor. Why this? Because they compare 2 groups, the patient who received radiation and the patient who didn't receive radiation, and this is the result. We have 82 increase in the risk for developing the second brain tumor. Also, we describe the case of meningioma because, firstly, because it is a rare histological variety, and also because it occurred 16 years after the first radiotherapy. So we can suggest that the radiotherapy induced the emergence of this meningioma. Also, Barman and colleague, in a study of selected patients, he reports that a younger age of radiotherapy was associated with the development of malignant tumor and also with the development of benign tumor. And the best example is meningioma. we can consider that the irradiation of a cell results in increased rate of metagenesis. So this irradiation contributed to the occurrence of brain tumor. Why this? Because this irradiation is the causes of mutation of the cell, and the mutation of the cell, this mutation is the cause of emergence of the secondary brain tumor. This is the mechanism of action of the radiotherapy on the cell of our brain. As conclusion, my message to convey to you is, if you have one patient who have received radiotherapy, you should have a good monitoring for this patient. You should have program long-term monitoring for this patient. So the follow-up of this patient is very important, because this radiotherapy can induce a secondary brain tumor. So you pay attention to the patient who received radiotherapy especially at the age of at a very young age. For instance, our patient, the case number 2, the patient received radiotherapy at the age of 20, and at the age of 37, he presents a secondary brain tumor. So you must take into consideration when developing a treatment protocol, especially in children and also in the patient with a genetic predisposition to the cancer. So longer-term monitoring arrangement should be established and based on the foreseen risk. And thank you very much for your attention.